We are at a planned home delivery for a full-term baby. We aren't expecting any problems, but it is useful to set up an area for the baby after it is born. Take a note of the time, as this can be helpful later on. When the baby is born, the most important thing is to dry and wrap the baby, as the baby can get cold very quickly. After this, you need to assess the baby and may need to leave the baby attached with a delay to the cord clamping for up to 3 minutes. This is good practice for term babies and particularly for preterm babies, provided they are well at delivery. However, if the baby is unresponsive, then it is more important to start resuscitation, and cord cutting may be required in order to achieve this.
I'm just going to have a look at baby. So we need to clamp and cut the cord here.
Okay.
It looks like we might need to help your baby to breathe. So what I would like to do is assess your baby over onto the floor here. So can I take baby and bring baby down to the floor so I can assess baby?
When the baby is dried and wrapped, we're going to assess the colour to see if the baby looks blue or pale instead of the nice normal healthy pink colour, and we're going to see if the baby is responsive, whether the baby is floppy and whether the baby is making any breathing effort. Finally, we want to assess the heart rate by listening with a stethoscope.
Okay, the heart rate is slow, so what I do need to do is take baby over to the resuscitation area and start some inflation breaths for your baby to help baby to breathe. Okay.
This baby is not breathing and has a slow heart rate. We need to put the baby in the neutral position. This will straighten the airway. The baby is looking straight up towards the ceiling.
Okay, so Tracy, David's baby does need help with its breathing. My colleague has gone to call the ambulance and I'm going to start to help your baby to breathe. She's going to come, yeah, the ambulance is be on its way soon, and I'm going to help baby to breathe, and then I'll be able to give you an update on your baby in a few minutes.
Emergency, what's your emergency?
Oh, hello, I'm a community midwife at a home birth. I need an ambulance, a time-critical dual paramedic ambulance for a newborn baby who's requiring resuscitation, please.
Okay, can you just confirm the location of this incident, please?
Yep, we're at number 7, London Way, RG7 7TR.
Okay, I'm just going to ask you a series of questions. Some may not seem relevant, but this will not delay an ambulance response.
Okay.
You say it was a baby.
Yes.
Has the baby just been born?
Yeah, the baby's about 2 minutes old now.
Okay, and you say you're a midwife.
Yes.
Not the person speaking. Are you a registered midwife?
Yes, I am.
Okay, perfect. And is this an inter-hospital transfer request?
No, it's an emergency. I need a paramedic to come here to the address, please.
Okay, perfect. Do you need advice about what you're going to do?
No, 2 registered midwives are on scene and we're both trained in neonatal resuscitation.
Okay, and so you want a emergency response. Okay, an ambulance response has been arranged for you.
Okay.
Just stay on the line for a moment and we will transfer you over to a clinician or a consultant midwife in our control room who may bring you back. Otherwise, then please carry on what you're doing.
Okay, thank you.
We have selected an appropriate size mask which fits over the nose and mouth quite comfortably and have attached the self-inflating bag. The midwife is careful to ensure she has a good seal between the baby's face and the mask by paying careful attention to her 3 Ps. First, ensure the mask is correctly positioned, then apply gentle downward pressure to the mask, and the third is to pull the jaw into the mask using the fingers that are placed along the jaw. We are going to do 5 inflation breaths. These are slow breaths which last 2 to 3 seconds and open the baby's airway. We should look at the baby's chest to see if we can see the chest moving. After we've done the 5 breaths, we need to reassess the response. We listen to the heart rate with a stethoscope to see if it's responded, and if it hasn't responded and the chest has not risen, then we need to repeat the inflation breaths again, because we have not successfully got air into the baby's lungs. There is no point progressing to cardiac massage at this stage, as it will not be successful. You can see now that she has readjusted her hands so that they are in what's called the single-handed jaw thrust. Fingers are placed along the jawline, careful not to squash the soft tissue underneath, as this will compress the airway. She repeats the 5 slow inflation breaths, lasting 2 to 3 seconds, again looking carefully for chest movement. She then again assesses the heart rate to see if it's responded. The midwife still has not successfully seen the chest rise. Her options now will be to consider 2-handed jaw thrust, which can be very helpful if you have a second helper. If the helper is not available, then other methods need to be considered. We would look at looking into the airway to see if there's any large matter there, and the best way to do this is to use the laryngoscope. If any matter is seen, then use a large bore catheter or Yanker sucker to suck out the airway and clear it. The other option at this stage will be to consider a Goodell airway. This can be measured from the centre of the mouth to the angle of the jaw, and the Goodell is carefully placed in the mouth, lifting the tongue out of the way with the laryngoscope and slid in as if the baby is naturally swallowing it. This will then secure the airway internally and mean it is easier to maintain the airway for a longer period of time. Once the Goodell is in place, you should do another 5 inflation breaths and watch the chest again to see if this time you've successfully achieved chest movement. In this case, the chest has moved and the heart rate can be reassessed.
Okay, I've called an ambulance. The ambulance is on its way. The ambulance knows it's urgent and they'll get here as soon as possible. We're going to continue resuscitating your baby here, but the ambulance is on its way. If you feel unwell at all or you feel like you're bleeding, you must tell us, okay, while we are here with your baby. Okay?
I've got good chest movement,
Brilliant.
but the heart rate is still low.
This baby is clearly very unwell and we've already got help on the way. The baby's chest has risen, so the airway is open, but the heart rate remains slow. So we need to give 30 seconds of ventilation breaths at a rate of 30 breaths per minute to oxygenate the baby. These breaths are shorter than inflation breaths. After 30 seconds or 15 breaths, reassess the heart rate. In this instance, the heart rate remains slow and we have completed ventilation breaths, so we now move on to chest compressions. The cycles need to be done in a 1:3 ratio, 1 breath to 3 chest compressions. The chest compressions need to be enough to compress the chest by 1/3. The midwife encircles the chest with both hands, with her fingers behind the baby's back and the 2 thumbs over the baby's sternum just below the nipple line. The compressions need to be much quicker than you would do in an adult resuscitation. We should be achieving 30 breaths to 90 chest compressions in 1 minute. This continues for 15 cycles or about 30 seconds. It can be very helpful to count the cycles out loud so both rescuers know at what point they are in the resuscitation cycle. Every 30 seconds the baby should be reassessed to see if there has been any response, and the second rescuer can listen to the heartbeat to see if this has increased. As we are doing cardiac massage, we should add oxygen at 10 litres at this stage. Ideally, a saturation monitor should also be placed on the right hand in order to assess the response.
One,
1, 2, 3.
1,
1, 2, 3.
1,
1, 2, 3.
1,
1, 2. Oh, that's the ambulance.
One.
If you could answer the door and let them in, that'd
One.
be great. 1, 2, 3.
1,
1, 2, 3.
Hello, ambulance.
1,
Oh, hi, in here.
1,
1, 2, 3.
1,
Hi,
1,
Adam and
2,
Nick from
3.
the ambulance
Hello.
service.
1,
Would you like me
2,
to
3.
take over that for you?
1,
Yeah, that's great. Thank
One.
you.
Okay, thank you. 1, 2, 3.
1,
1, 2,
Okay,
3.
I can let you know
One.
what's been going on.
Yes, please.
Adam, so
One.
it's a term baby,
One.
planned home birth. Baby's
One.
about 10 minutes old now and
One.
requiring CPR.
One.
There aren't any risk factors. We've
One.
had good chest
One.
movement and there's an
One.
airway in
1, 2,
situ.
3.
1,
So the heart rate was last
One.
assessed about 20 seconds ago
One.
and it was slow.
1,
The baby's receiving oxygen
One.
at 10 litres.
1,
We're going to need to transfer this
One.
baby in the ambulance to hospital. The ambulance will need to be
One.
nice and warm and close to the
One.
front door, please.
Yeah,
One.
Nick, if you wouldn't mind doing that for me, mate, sort that out.
1,
Get the vehicle to the door. Right.
We're also going to need, Nick, we're
One.
going to need to continue oxygen in the
One.
ambulance, and if you've got a
One.
saturation probe for the baby, we're going to
One.
use that as well, please.
1,
Okay,
One.
Tracy, are you okay? So I'm going to stay
One.
with Tracy, and then
3.
Catherine's going to transfer into the hospital with the
One.
baby with you.
2, 3.
1,
1, 2, 3. Okay, Catherine, what we're going to need to do, once Nick's got the ambulance ready, is get ready to scoop up and run, okay?
Yeah.
And what I'm going to propose to do, if we just spend a minute or so doing CPR with good airway management so we can pre-oxygenate, and then we can literally just carry the baby out with CPR ongoing. All right, it's going to sacrifice the airway management part of it, but it's just going to be a matter of seconds while we get onto the ambulance, all right?
okay. Yeah, no, I'm happy with that. I just need to keep the baby warm, so I just need to put a hat on and make sure the baby's wrapped up.
I can do
Juliet,
that,
could you
yeah.
do that for me? Put a hat
No
on
problem.
so I can continue with the airway.
So the baby's hat's on nice and snug there.
When possible, transfer the baby to the ambulance, keeping the baby warm and continuing cardiopulmonary resuscitation en route if possible. The ambulance has been pre-warmed before the baby is transferred, and the baby should be kept warm throughout the transfer to the hospital. Modern cooling practices have improved outcome for babies who are having prolonged resuscitation, but decisions about cooling should wait until the baby arrives at the hospital and a medical team can decide whether this is appropriate. The team are now in the ambulance, continuing cardiopulmonary resuscitation. It is important that the midwife and paramedics discuss where they should sit in the ambulance to ensure that there is a safe transfer. Ideally, everyone should be sitting, and it is recommended they are strapped in place. Adjustments may be made in order to ensure that the airway is maintained and cardiac massage can continue. You may at this stage wish to change to single-handed cardiac massage done by a single rescuer. This is with 2 fingers in the centre of the chest, compressing to the same depth as before and at the same ratio of 1:3. This may be easier than having a second rescuer trying to reach over the baby in an unsafe position.
Was born full term but was born with no respiratory effort and very little cardiac output. She was a blue baby, very poor tone, no resps and a heart rate of 60 on the midwife's arrival. CPR is ongoing with a Guedel in place. Current SATs are at 61, heart rate of 60 and our ETA is roughly...
The midwife or paramedic should ensure that they can see the baby's chest and that it's rising with each breath. They may wish to balance the ambu bag on their arm so that it is more stable. In the ambulance, saturation monitoring is available and should be used by placing the saturation monitor on the right hand. Oxygen should be continued until the baby's heart rate is above 100 or the saturation is above 90. It is important that the paramedic team know which hospital is expecting them and also where the receiving team will meet them.
So our resuscitator is on and pre-warmed, and we have our crash trolley here. Let's go through our A, B, C, D, E. So airway we have should be an appropriately sized mask, and we'll check our gas cylinders and also suction. In terms of drugs, we need to get those ready in case we need adrenaline and also some access that would be helpful to have nearby.
So they're all over there on the crush trolley waiting for us. We've got those out already.
And along with some ET tubes, I see.
Yeah.
All right. So if you wouldn't mind putting the monitoring on when the baby gets here, and if you wouldn't mind continuing our chest compressions, I will do breathing for baby.
Hello, do you want to put the baby on here and hand over to us, please?
Thank you.
Okay guys, this is a 15-minute baby girl. She was born at home after a routine delivery and a non-complicated pregnancy. However, at birth she had no respiratory effort and very poor cardiac output. She's been given full and effective BLS CPR by the midwives, both prior to my arrival and en route. And I'll allow Catherine to give you the more sort of specifics about this girl.
Okay.
Thank you.
So I can feel the chest moving. Do you want me to start CPR?
Please.
'Cause the heart rate's very slow.
Yep.
Ready? 1, 2, 3.
1.
1, 2. In summary, we followed the Newborn Life Support Resus Council algorithm in the home setting. It is certainly possible to do so even with basic equipment. Key aspects we would highlight in the out-of-hospital setting are keeping the baby warm, providing oxygen if the resuscitation is prolonged, and maintaining the airway throughout the process. Safe transfer in the ambulance is vital, and it's important that paramedics and midwives discuss this as each case is individual. Clear, calm communication between all team members and the parents is important at all stages of the transfer. Good teamwork and effective use of the Newborn Life Support algorithm gives these babies the best chance of survival.